Burns and principles of plastic surgeries. Skin histology, formed of two layers, epidermis and dermis. Epidermis formed of stratified squamous epithelium, while the dermis is formed of connective tissue. The skin appendages, hair follicles, sweat glands, and sebaceous glands arise from the epidermis and grow down into the dermis. When epidermis is damaged and burned, epithelium from these appendages can creep up to cover the burnt area. Functions of the skin: forms a barrier against invasion by microorganisms, prevents excessive loss of water from the body, regulates body temperature by secretion of sweat, formation of vitamin D, and finally sensory receptors in the skin protect the body from injurious insults. Skin is the second largest organ in the body by size and weight, next only to the muscles. Thus, loss of large amount of skin, if not replaced, is incompatible with life. Skin has limited ability of regeneration and lacks much of functional reserves of internal organs. Etiology of burn. Thermal injuries include scalds, flame burns, and steam burn. Scalds caused by boiled liquids often affect children. Flame burns affect any age and often due to setting clothes on fire, the most common burn in industrial accidents. Steam burn, inhalation and upper or lower respiratory airway burns due to exposure to hot gases. Electric burns, usually due to contact with an electric socket or low voltage battery. Contact with high voltage may be fatal, since blood and bones are good conductors. Every organ in the body may be affected. Chemical burns are due to whether acids or alkalis. Pathology of burn, the extent. Definition: the percentage of burnt skin surface area in relation to the whole body surface area. This follows the rule of 9. In children, the rule of 9 needs some modification due to large size of the head in comparison to the rest of the body. Classification: major burn, if more than 30% of the body surface area are burnt. Intermediate burn, 15 to 30% in adults, 10 to 30% in children. Minor burn, if less than 15% in adults and 10% in children. According to the depths, we have first-degree burns, second-degree, and third-degree. First-degree burns that damage only the epidermis, skin, erythema. The usual example is sunburns. Healing: they heal rapidly. Appearance: formation of blisters surrounded by erythema. Their surface is mottled red and usually moist due to plasma exudation. Presence of pain: very painful and sensitive to air. Second-degree burns, the epidermis and a portion of the dermis, provided that no infection, epithelial regeneration can occur from remnants of hair follicles and sweat glands and dermis, and heal in 3 weeks. If infection occurs, epithelial elements are destroyed and will be changed to full-thickness burn. They should heal within 3 weeks, and appearance and presence of pain are the same as first degree, very painful and sensitive to air, and formation of blisters surrounded by erythema. Their surface is mottled red and usually moist due to plasma exudation. Third degree burns, the epidermis and dermis are completely destroyed. Epithelial coverage only by epithelial migration from the edges of the burnt area. Slow process. After scar separation by the 3rd week, prepare for skin grafting. Appearance: the area is dry, white or black scar. Burn slow. Present with possible visible thrombosed subcutaneous vessels. Presence of pain, painless due to loss of terminal nerve endings, elicited clinically by pinprick test. Second degree burns, further subdivided into superficial partial thickness burns and deep partial thickness burns. Superficial partial thickness burns heal with epithelialization in 10 to 14 days, while the deep partial thickness burns, slower to heal, 25 to 35 days. Cells from the residual uninjured epithelium of deep sweat glands and hair follicles creeps up to cover the surface. Note: burn can be classified into superficial, 1st and 2nd degree, while deep in 3rd degree. Histopathology: human skin is injured by heat in 2 ways: immediate direct cellular injury and delayed injury due to progressive dermal ischemia. The degree of tissue destruction is related to temperature, duration of heat exposure. Cause of cell damage is protein denaturation and many are reversible. However, at temperature more than 45 degrees Celsius, it's irreversible. Histologically, skin thermal injury results in 3 distinct trauma zones: central inner zone, zone of coagulation; intermediate zone, zone of stasis; and outer zone, zone of hyperemia. Central inner zone, zone of coagulation, forms the inner layer of the visible burn scar, and we have, if it's left, the scar separates within 3 weeks, leaving bed of granulation tissue in full thickness burn or re-epithelialized bed in partial thickness burns. The intermediate zone or zone of stasis surrounds the zone of coagulation. It contains viable tissues which may die over the next 48 hours if tissue oxygenation and adequate nutrition are not maintained. The outer zone or zone of hyperemia. This area contains inflammatory mediators, prostaglandins, histamines, and kinins. Formation of tissue edema normally recover within 7 to 10 days unless subjected to infection. The rate of burn healing depends on the density of the surviving adnexoepithelial structures within the derms, especially hair follicles and sweat glands, which are present deep to the epidermis. In a partial thickness burn, healing is achieved by epithelialization within 3 weeks without any surgical intervention. In a full thickness burn, eschar formation separation occurs at about 4 weeks, leading to clear granulation tissues, which heal by fibrosis and scarring if left without grafting. Pathophysiology. The following pathological sequelae occur in burned patients: increased capillary permeability leading to loss of fluids and proteins in the damaged areas, maximum in the first 8 hours and continues for 48 hours, excessive loss of water by evaporation through the burned skin. A patient with full thickness burn can lose up to 200 milliliters per hour. The body loses 560 kilocalories for every liter of water evaporated, leading to severe dehydration and catabolism, increased metabolic rate and nutritional demand. And we have immunosuppression, both humoral and cell-mediated immunity. The burnt area is colonized by bacteria which are impossible to eradicate except after skin coverage. Complications. Systemic complications such as inhalation injury immediately from inhalation of heat or noxious gases, leading to asphyxia, edema of the upper airways, bronchospasm, progressive hypoxia, and finally hypercapnia, followed by atelectasis, pneumonia, pulmonary emboli, emphysema, and pulmonary edema. Finally, respiratory failure occurs with systemic sepsis. Proper oxygenation is essential to avoid such complications. Neurogenic shock caused by pain, hypovolemic shock if fluid losses are not properly corrected. Renal failure, acute renal failure can occur after prolonged uncorrected hypovolemia. GI complications, Curling's ulcer, acute ulceration of stomach and duodenum, rarely seen nowadays with routine prophylactic use of antacids and H2 receptor antagonists during the initial burn management. Ileus usually occurs early in post-burn period and may necessitate insertion of nasogastric tube. Acute colon ulcerations may be deep, reaching the serosa, secondary to fungal infection. Multiple organ failure or poor outcome may follow major burns, particularly with sepsis. Local complications, early local complications, infection, primary cause of death in burned patients may be bacterial, viral, or fungal, can occur for both exogenous and endogenous sources. Complications lead to septicemia and septic shock, timing usually between the 4th and 7th days post-burn. Treatment by prevention through proper local burn wound care. The value of systemic antibiotics in prevention is doubtful. Constricting scars. In deep circumferential burns of the limbs and chest, it restricts chest expansion. Treatment, urgent sclerotomy. Suffocation due to edema in burns of the face and neck. Treatment, urgent tracheostomy. Compartment syndrome, delayed local complications. Contractures across joints, scar formation, hypertrophic or keloid. Malignant transformation, Marjorine's ulcer in long-standing unstable scars is rare. Management of burn. First aid, admission to hospital, resuscitative fluid therapy. First aid, ensure patent airway. If there is airway obstruction, endotracheal intubation. Strong analgesic as 50 mg pethidine is administered IV. Tetanus prophylaxis. Pour saline or tap water at room temperature over burnt area for 15 minutes. It limits burn depth, decreases edema, and relieves pain. Admission to hospital indications, inhalation injury, burn size more than 15% in adults or 10% in children, any full thickness burn, burn in association with trauma or comorbidity, electric burns and chemical burns, resuscitation, inserted a wide-bore IV cannula rapidly before veins collapses, and we have introduction of a Foley urethral catheter to check out urinary output, resuscitative fluid therapy. The amount and rate of fluid replacement are determined by patient's weight, percentage of total body surface area injured, given for the first 48 hours, and after that according to the response of the patient. A maintenance therapy may continue. The greatest fluid loss occurs during the first 8 to 12 hours post-burn and continues more slowly over the next 12 to 16 hours. The amount infused during the first 24 hours is 2 milliliters per percent surface area burned per kilogram body weight. Half the amount calculated is given over the first 8 hours and the other half over the next 16 hours. Also, half of the calculated amount is given over the second day. Concerning the types of fluids, it is variable in each formula, where administration of 2000 milliliters of glucose, 5% solution. Administration of blood is needed in major deep burns started after 48 hours, guided by hematocrit value. The commonest formula used, Parkland's formula, 4 milli per kilogram percentage, burn lactated Ringer's solution per day. Half the amount is given in the first 8 hours, quarter in the second 8 hours, and the other quarter in the third 8 hours. In all formulae, the maximum percentage of burn calculated is 50%, otherwise serious over-infusion may occur. Oral intake is avoided during the first 8 hours to avoid GI complications, and it's started gradually after that. Intramuscular injections are avoided because absorption is poor, and using ice-cold water from a refrigerator is contraindicated because it induces more tissue damage. Minor burns, less than 15% in adults and 10% in children, are treated as outpatients by dressing using proper local chemo and therapeutic analgesia. Treatment essentially consists of fluid therapy, compensate for losses, local burn wound care. The types of fluids used in replacement is different in each formula. Only crystalloids, saline or lactated Ringers over first day. Others, half the amount should be crystalloid and the other half to be colloids, such as dextran. The value of systemic antibiotics in infection prevention is controversial. Monitoring the adequacy of IV resuscitation by regular checkup of vital signs. Urine output should be 0.5 to 1 milliliter per kilogram per hour. Central venous pressure in critical cases. The nutritional status shouldn't be neglected. Patients with extensive burns are liable to have serious catabolic status due to anorexia, sepsis if present, extensive water and caloric losses. IV hyperalimentation has made it easy to correct this problem. However, enteral nutrition is preferred. Local burn wound care, early care, sclerotomy. Do it immediately for constricting scars in limbs and chest. Sometimes fasciotomy in deeper burns may be limb-saving. Cleansing. Remove loose skin and initial conservative debridement to avoid infection. Topical antimicrobial agents. The ideal topical cream should be in a water-soluble base, prevents dryness, not painful, non-allergic, and non-toxic. Most importantly, bactericidal, but not injurious to viable cells in the burn wound. The most three commonly used are silver sulfadiazine, mafenide acetate, and silver nitrate solution. After local cream application, the wound is managed by either exposure method or closed method. Exposure method definition: leave the wound exposed, requires patient isolation in completely aseptic atmosphere and following all aseptic rules by the personnel dealing with the patient. Indications: burns of the face, neck, and perineum, burns involving one side of the trunk. Advantages: more comfortable to the patient, avoids repeated change of dressings, burden and expensive, inhibits growth of anaerobic bacteria. Closed method definition: covers a wound by a bulky occlusive dressing which is changed every 2 to 3 days depending on the state of the wound. Indications: circumferential burns, limbs to prevent stiffness and adhesions. Advantages: decreasing cross-infection, decreasing fluid loss by evaporation, decreasing pain by covering exposed nerves, and decreasing tissue edema by compression. Later care for deep burns: autologous skin grafting, biological dressings, and prevention of contractures by proper splintage, immobilization in the best functioning position, and physiotherapy. Autologous skin grafting: we have grafts. Partial thickness skin grafts are commonly used to cover the large raw areas produced by the burns. A graft is applied after either spontaneous separation of a scar from 3 to 4 weeks or early burn wound excision, the preferred method for deep burns, especially in the hand. Biological dressings indications: autografts are not enough or local wound conditions are not favorable. Advantages: the wound will be less painful, minimize fluid and protein, controlling infection. Examples: allograft, the cadaver's skin, xenograft or xenoskin from pig skin, amniotic membrane. More recently, artificial skin substitutes are used, applied only after scar removal and changed every 3 to 4 days. Prevention contractures by proper splintage, Immobilization is the best functioning position in physiotherapy. Following early wound care or partial sickness burns heal within 2 to 3 weeks, while full sickness burns require closure by autogenous grafts. Grafts are applied 3 to 5 days post-burn before bacterial infection sets in, after tangential excision of the damaged derms and reaching healthy bleeding tissues. Biological dressings are only temporary, and permanent closure can be achieved only by autologous skin graft. Special types of burns: we have electric burns, inhalation burn, chemical burns, cold injury. Electric burns divided into high and low tension injuries according to the voltage responsible for the injury, whether above or below 1000 volts. The tissue damage is due to passage of electric current through blood and bones. The affected blood vessels usually show late thrombosis, leading to delayed progressive ischemic necrosis. Clinically, 3 types of skin damage may result in: contact burns occur at points of current entry and exit from body, burns from current exit and re-entry at adjacent parts, thermal burns from ignition of clothing due to heat generated by the current passing through the body. Inhalation burns: flames or very hot air may be inhaled, causing burns in the upper respiratory tract, leading to laryngeal edema, stridor, or lower respiratory tract pneumonia and acute respiratory distress syndrome, leading to respiratory failure. Suspected and facial burns: carbonaceous burns, closed space burns, and burnt nasal hairs, wheezing, pharyngeal edema or hoarseness of voice. Management: early intubation, high flow oxygen, and hospital admission with possible need for mechanical ventilation. Chemical burns: chemical agents burn by oxidation, reduction, corrosion, or protoplasmic poisoning. The severity is determined by its amount, the strength of the agent, duration of skin contact, and its mechanism of action. Management: systemic and locally. Systemic by administration of the proper antidote in case the agent is absorbed, or locally, thoroughly clean the agent. All saturated clothes are removed and affected areas are irrigated with huge amounts of water. Cold injury is a form of thermal injury which is due to exposure to cold. Depends upon duration of exposure. Temperature usually affects hands, feet, ears, and nose. Examples: frostbite, trench foot, and chilblain. Then we have prognosis of burns, burn factors, patient factors, and treatment factors. Burn factors: extent, the most important factor. Mortality is about 50% if the extent of burn is 50%. Depth: deeper burns carry higher mortality and more disfigurement. Site: burns of the face are the worst because they are likely to be associated with inhalation burns of the respiratory tract. Infection: septicemia is the major killer of burn victims, not bomb victims. Type: high voltage electric burns are the worst, usually fatal. Scalds with boiling water, superficial burns, and the least harmful. Associated injuries. Patient factors: age, extremities of age, children, and elderly. Bad prognosis: concomitant diseases as diabetes and coronary heart diseases. Treatment factors: those treated in specialized centers, better chance of survival and avoidance of complications. And then we have principles of skin coverage. Skin defects result from trauma, burns, or following surgical resection of different benign and malignant lesions. Methods of covering: we have skin graft and flaps. Skin graft may include an underlying tissue as subcutaneous tissue, muscle, cartilage, or bone. They are termed composite graft. Skin graft definition: a tissue which is completely detached from its blood supply in the donor area and receives its new blood supply from the base of the wound in the recipient area. We have 2 types of skin grafts: split thickness or full thickness. Split thickness definition includes epidermis and part of the dermis. Advantages: survive easily, good take, donor sites heal spontaneously. Disadvantages: few qualities of normal skin, marked contraction, weak resistance to trauma, poor sensation, and aesthetically poor. Full thickness graft includes epidermis and full thickness of the dermis. Advantages: all qualities of normal skin, minimal contraction, resistant to trauma, better sensation, aesthetically better, but disadvantages are less take, donor site must be closed surgically, and donor sites are limited. Graft survival: a graft must obtain a blood supply from its recipient bed to survive, so vascular status of bed determines skin graft survival. Take: new vascularization, new vessels which grow from the recipient bed take about 5 to 7 days to be established, depending upon size of the graft, status of the recipient bed, and graft thickness. During neovascularization, the graft needs to be supported by some form of embolization and mild compression. Poorly vascularized tissues such as bare cortical bone devoid of periosteum, bare tendon, and bare cartilage will not take a skin graft because they can be covered by flaps. The thinner the graft, the faster the take. A small graft takes rapidly. Technique: full thickness graft obtained from anywhere in the body using scalpel blade, taken from an area close to the recipient site for better color matching, from above the clavicle or post-auricular area to cover facial defects. Split thickness graft obtained by a special knife, it's called dermatome. The skin is the dermatome. From hidden areas as a size, the donor site heals with complete epithelialization within 3 weeks. The epithelium is derived from that of the skin, appendages, hair follicles, sweat glands, or sebaceous glands that have deep extensions into the derms. Flaps. Definition: tissues to be transferred from one side of the body to the other, maintaining their blood supply for nourishment. Types: we have skin flaps, musculocutaneous mycutaneous flaps, fasciocutaneous flaps, and microvascular flea flaps. Skin flaps, they are classified into local and distant. Local flaps are subdivided into random pattern flaps or axial pattern flaps. Random pattern flaps have anatomically recognized blood supply, should have strict length to width ratio to survive. Safety random pattern flap has a length to width ratio 2:1. Axial pattern flaps supplied by a known artery, no limitation as regarding length to width ratio. The whole area supplied by specific cutaneous artery which can be transferred safely. Adjacent nerves may be included. The flap will be a sensory one. May return their skin attachment to donor area. Pedicled flaps. If they retain their blood supply without skin attachment, they have wider arc of rotation. Island flaps. Distant pedicle flaps keep the recipient attached to the donor site for a period of 2 to 3 weeks to allow for new vascularization before separating the base. Examples: flaps from the abdomen or groin to resurface the hand, or from one leg to the other. Cross leg flap. Musculocutaneous or mycutaneous flaps. These are axial flaps which receive blood supply from the underlying muscles through perforator vessels. The muscle is lifted from its bed with overlying fascia and an area of the skin retaining the neurovascular pedicle of the muscle. Then rotate the whole flap in an arc to cover the raw area. The incorporation of the pedicled muscle in the flap enhances the survival of the cutaneous component. Examples: latissimus dorsi mycutaneous flap is famous, used to cover defects resulting from wide radical mastectomies. Pectoralis major mycutaneous flap to cover neck or face defects. Fasciocutaneous flaps advantages: avoid functional deficit of the muscle transfer and excess bulk of mycutaneous flaps. Their blood supply is through fasciocutaneous perforators. Microvascular free flaps. It's now possible to anastomose vessels less than 1 mm in diameter with the advent microvascular techniques, so it's now feasible to transfer an axial flap from one side to the other by anastomosing artery and veins of the flap to the corresponding vessels in the recipient area without the need for keeping patient immobilized for 2 to 3 weeks and possible joint stiffness. Tissue expanders, they are inflatable silicone implants. Technique: they are placed subcutaneously in collapsed state. Over several weeks, the expander is gradually inflated with saline through subcutaneous ports. The overlying skin is gradually stretched to accommodate a larger area. Finally, the expanded skin can be used to cover defects, and the tissue expander is removed. Aesthetic surgery. Definition: surgery intended to improve appearance for correction of any disfigurement, as in scar revision and enhancement of the normal appearance by correcting a deformed nose or correcting the effects of aging process in the face. Examples: rhinoplasty, correction of deformed nose; facelifting, getting rid of the redundant excess skin of the face which occurs with aging, done through scars that are hidden in hair or just in front of the ears or in a natural crease. Recently, they can be carried out through endoscopic techniques. Eyelid surgery: aim, correct aging process affecting eyelids through very fine incision in their creases. Breast surgery, whether augmentation mammoplasty to enlarge small breast by insertion of a silicone implant under the breast, or reduction mammoplasty to reduce large breast. Liposuction. Definition: body sculpturing surgery by aspiration of excess fat accumulating in the abdomen, buttocks, or trochanteric areas. Method: insertion of special cannula through 1 cm skin incision. The cannula is connected to a special machine with high vacuum pressure to allow aspiration of the excess fat. The selection of patients for aesthetic surgery is important since there's no pathology, but it's just improvement in the body image they asked for. Sometimes The aspirated fat can be treated in a special manner and re-injected to augment other areas in the body with depressions, and this is called autologous fat injection. And this concludes our part for the plastic surgery for today.